Hi guys, I'm Dr. Alexander Balan and today we'll continue to discuss anesthetic considerations and at this time in the geriatric population. Objectives of our lecture is to describe physiologic changes, identify risk factors for perioperative morbidity and mortality, review some anesthetic techniques, summarize common perioperative complications. Important part is that modern healthcare advances over the past century and have significantly increased the average lifespan worldwide. And it means that if people lived not too long, some past time ago, now they are living a little bit more, and of course, management of the pathologies like diabetes mellitus and hypertension, and availability of surgeries for removing some organs or part of organs and increase the quality of life increases. And this is the reason of increased average lifespan. This is good, but of course the geriatric population requires at times to address to the hospital and take some surgical procedure for different pathologies. And at that moment we need to give anesthesia to patient and know which type to give to produce less complications and make a fast awakening of patient. Physiologic changes, like this phrase is golden and you have to memorize, like normal aging is associated with decrease in reserve and function of all major organ systems and limiting the available response to acute stress. So decreased vital reserve and function and decreased response to acute stress. And remembering this phrase, you'll go through all the system and will get answer. A decreased beta response and baroreceptor reflexes. So less sensitive baroreceptor. It means that in time of hypertension, patient do not compensate with tachycardia as rapidly as usually should be. Increased calcification, stenosis, and rigidity of arteries, increased systemic vascular resistance, and decreased compliance. This could be a cause of hypertension, wide pulse pressure, labile hypertension, or not well controlled hypertension from reason of some vasopathy or pathology of arteries. Marked hypotension upon induction with intravenous anesthetic agents. So you should take in account that administer less anesthetics during induction to do not have a marked or severe hypertension on induction. Difficulties with controlling postoperative hypertension when awakening period of patient, it could have increased hypertension, and of course increased the risk for any myocardial or cerebral vascular event. Coronary atherosclerosis is not a component of normal aging. So remember, not a component of normal aging. If patient have atherosclerosis, it should be treated, and it is a component of metabolic syndrome, of dyslipidemias, and so ahead. Display a higher prevalence of coronary artery disease and are at higher risk of for perioperative coronary ischemia, elder patient. Left ventricular hypertrophy, widening of pulse pressure with decreased diastolic blood pressure. Chronic hyperglycemia synergistically increases myocardial oxygen demand and decrease coronary perfusion. So coronary perfusion is dependent on normal range of blood pressure, controlled glycemia. Age more than 65. So the annual incidence of myocardial infarction in age more than 65 is from 7.8 to 25.6 per 1,000 person in US, and it's still high for this age, like more than 65. And poorly treated systemic hypertension and atherosclerosis accelerates the rate of hypertrophy of left ventricle. Avoiding tachycardia and hypotension are general principles to improve coronary perfusion and avoid some ischemic event like myocardial ischemia or infarction in older patients. Aging of the cardiac conduction system increases the incidence of ectopic beats. So arrhythmias, most age-related arrhythmias develop gradually due to fibrotic changes, and they are not acute one, inhibiting conduction pathway and promoting re-entry pathway. Premature atrial and ventricular complexes, atrioventricular blocks, bundle branch blocks can complicate the care of geriatric patients. And atrial fibrillation from all of them is the most common arrhythmia and develops secondary to diastolic dysfunction and as left atrial dilation and fibrosis. So increasing in volume of cavity or in size of cavity, left atrial, and distension of the wall, and of course wall contains this nodes and fibers to conduct the signal, and of course disruption of conduction from the sinoatrial node to the AV or atrioventricular node. So this pathway is going through the atrium. On pulmonary system, we have 1/2 of all perioperative deaths in geriatric patients are related to these pulmonary complications. There are many changes like increased work of breathing, the chest wall stiffness, diaphragm flattens, and intercostal muscle weaken. Decrease in inspiratory capacity, decrease in functional residual capacity. Respiratory fatigue is in the setting of residual neuromuscular blockade and opioid use. It means that patient even when wake up from anesthesia and become a little bit conscious and opening eyes and so ahead, but have fatigue and decreased muscle ability to contract and make spontaneous adequate respiration. At the parenchymal level, lung changes mimic those of emphysema. Alveolar airspace and physiologic dead space increases, while surface area decreases, and it causes ventilation perfusion mismatch with a ventilation component altered. Closing capacity increases. Aging causes blunting of central response to hypoxia and hypercarbia, especially in obstructive pulmonary diseases, and decrease respiratory drive up to 50%. Blunting of the central response to hypoxia and hypercarbia can be seen during induction of anesthesia or administration of premedication, and you will see the patient become really unresponsive to any changes in decrease in saturation or SpO2. Neurologic changes like an elderly patient is reliably anesthetized with up to 30% decrease in concentration than a young adult. When you have elder patient, you have to think about less dosage in comparison with a normal adult patient. Common potentially inappropriate medications used by anesthesiologists include some of them by premedication and with preparation of patient to induction, like diphenhydramine, which is antihistaminic, scopolamine, which is anticholinergic drug that is formerly used for treating motion sickness, and of course for pre- and postoperative nausea and vomiting, and for drying all the secretions. Benzodiazepines for sedation, metoclopramide, antiemetic, meperidine, and NSAID, non-steroidal anti-inflammatory drugs to blunt pain or reaction. As the brain ages, can occur loss of brain volume, cerebrospinal fluid, and dendrite synapses. It can cause memory loss, cognitive decline, any alteration in cognition, sleep disorders, delirium, depression, and decreased neuroplasticity. The diagnosis of dementia becomes relevant when memory and cognition limitations become severe enough. So two components, memory and cognition limitations severe enough, of course, to limit normal daily activities like going to the market or cleaning house or anything like that. So it's relevant for diagnosis of dementia. And dementia leads to incomplete or inaccurate medical history and medication lists. Patients do not remember which drugs taken previously or do have to take even today, or surgery history or anything related to complications or events during the life. And dementia increases the risk of delirium and postoperative cognitive dysfunction later. On the renal system, we have decline in glomerular filtration rate, or GFR, and as patient's age. Increased rate in diabetes may lead to hypertension and vasculopathy, or pathology of the vessels, further decrease in renal function. And you have to know that filtration rate decreases by 1 milliliter per minute per meter square each year after the age of 40. If you have 40, you are right on the limit of starting decline in filtration rate. Increased risk of acute kidney injury secondary to nephrotoxic agents. For example, non-steroidal anti-inflammatory drugs and intravenous contrast, which produce acute tubular necrosis, or can produce at least, at the risk of. Geriatric patients have decreased response to renin, adjuntazine, aldosterone, which is a triad, or they are. This mechanism is like compensatory to increase reabsorption of sodium and increasing vessel tone to increase pressure, and vasopressins that may have difficulty with volume status. Patient more than 75 years old have 20 patient old has 20 to 30% less plasma and intracellular volume. And you have to know this because intracellular volume or intracellular liquid can pass to intravascular in situations like dehydration, hypotension, or blood loss through hemorrhage, and decreased clearing capacity, of course. Endocrine and metabolism. So malnutrition is a common issue in elderly and strongly correlates with perioperative morbidity and mortality. And it may present acutely as a sharp decline in daily caloric intake and unintentional weight loss, or chronically as a body mass index of less than 18. Heat production, insulation, and the ability to thermoregulate commonly decline with age. Some important facts, like more than 15% of elderly in the United States have been diagnosed with diabetes mellitus. And you have to make check of blood glucose several times as a perioperative management. And patients with uncontrolled diabetes mellitus are significantly higher risk for coronary and peripheral artery disease. And all these complications to diabetes mellitus, like chronic kidney and end-stage renal disease, peripheral neuropathy, autonomic dysfunction, neurogenic bladder, and gastroparesis. And for this reason, if patient coming to the surgical procedure and if it is not urgency, you have to redirect patient to a specialist like endocrinologist and apply some treatment to the diabetes mellitus to make it in a normal or approximately in a normal range. Uncontrolled glucose levels place patient at highest risks of wound dehiscence and infection, and sepsis is with high rate of mortality for elderly patient. Preoperative assessment, like more than 20% of patients over 65 years undergoing surgery have baseline decline in cognition or cognitive deficits that place them at higher risk of worsened postoperative cognitive dysfunction. And there are elaborated and developed a lot of neurocognitive formal assessments like MMSE, Mini Mental State Examination, a brief cognitive screening tool, and any others. And you should assess capacity for medical decision making, like agreement of patient to procedures, of course surgical, one of often a procedure to make decision by self and not a first line relatives. Ensure that patient may act and converse normally. Accumulation of comorbidities, very important to assess. Grip strength, weight loss, gait assessment, cognitive tests, medical history are typical variables measured as frailty indicators and should be done every time to the elder patient. A clinical significance of everything. So monitoring. Anesthetists should follow ASA standards or American Society of Anesthesiology standards. And only qualified anesthesia personnel should be present and vigilant, of course, but should be present at the anesthesia of elder patient. Evidence-based, lower anesthetic doses decreasing postoperative delirium risks. And you should know that vital signs decreased and acute stress decreased response. So give less anesthesia to elder patient in comparison to anyone else. Positioning of the elder patient. Aging is accompanied by significant musculoskeletal changes. Stiff joints, particularly in the cervical spine, hips, shoulders, can prevent optimal patient positioning, like ankylosing spondylitis, very common in elder patient, and should be careful to not make some cervical luxation or movement of the cervical portion of spine. Avoid applying force against resistance to increase joint angles on the surgical table, and apply supportive cushioning and pads to rigid extremities. Geriatric patients have very fragile skin and decreased peripheral circulation, and sometimes it requires appliance of central venous catheters. Take additional care of avoiding causing skin tears and bruising, and apply extra padding to areas at risk for pressure ulcers, including sacrum and heels, of course. A general anesthesia. First, intubate the patient safely. If you need some help, you can ask for another anesthesiologist. Geriatric patients are often identity loss, making mass ventilation more challenging, and have decreased cervical extension from different osteoarthritis, ankylosing spondylitis, or anything like that, limiting extension and impairing direct laryngoscopy. Vasopressors and fast-acting antihypertensives should be available during induction to maintain safe and adequate blood pressure. For example, if you are making induction of patient and after administration of drug, measuring blood pressure and patient have 60 per 30 millimeters of mercury, you can administer immediately a bolus of infusion of normal saline infusion, or to establish some vasopressors to make more adequate blood pressure to perfusion of organs. Neuraxial anesthesia. Example of repair of fall related hip fracture lends well to spinal anesthesia. So patient is awake and have less chances to be obnubilated or with delirium after awakening from general anesthesia. So fewer pulmonary complications, especially in patients with lung disease. We are talking about neuraxial techniques. Not ideal for long surgeries, as patients with anxiety, patients who have difficulty lying comfortably in the required position for surgery, especially where it requires to stay more than 1 hour in a lying position. Preservation of pulmonary function and decreased sedation are ideal as long as the patient can safely and comfortably tolerate surgery. Neuraxial techniques are also relatively contraindicated in some coagulopathies, aortic stenosis, as decreasing blood pressure after Hemodynamic instability secondary to hypovolemia as vasoplegia or relaxation of the peripheral resistance. Also contraindications as anticoagulation, local and tissue infection at the site of administration or make a puncture of spinal block, respiratory dysfunction for nerve block near the phrenic nerve. Opioids, elderly patients are at higher risk of opioid-induced apnea and decreased hypoxic and hypercarbic respiratory drive to compensate for over-sedation. For opioids and for anesthetics as well, response in the same way with less compensation for hypoxic or hypercarbic state. Opioids are significantly more potent due to decreased clearance and increased neurologic sensitivity. A pain should be treated first with non-opioid analgesics, but of course during the surgery you will give opioids and will not treat pain with NSAIDs. With escalating treatment to weak opioids, then strong opioids until the pain is adequately relieved. So in time of a possibility to apply NSAIDs instead of opioids, you can do this. Otherwise, you should give, of course, opioids for pain relief and prevention. Consideration should also be given to renal dysfunction and limiting the clearance of morphine and its active metabolite morphine 6-glucuronide. The use of morphine places patients with decreased renal function at risk of apnea and prolonged effect of morphine and of course of metabolites of morphine. Meperidine should be used with caution in geriatric patients as it significantly increases the risk of postoperative delirium. Neuromuscular blockers. The bioavailability or availability of neurotransmitters and neuroreceptors decreases with normal age. This decrease often results in a prolonged duration of neuromuscular blockade for most agents. In the setting of respiratory dysfunction, these changes increase the risk of postoperative respiratory complications and reintubation. As I told you, patient is awake already and have to be extubated or removing the tracheal tube instead of we are waiting for restoration of muscle force and contraction. Fluid management has been a problematic area in all patients and especially in geriatric patients. It depends on cardiac and renal abnormalities and often have poor tolerance for hyper or hypovolemia. They present for urgent surgery very often at either extreme in terms of volume status, ranging from fluid overload in the setting of congestive heart failure to severe dehydration following a fall. Dehydrated patient may benefit from preoperative fluid resuscitation or drinking clear fluids up to 2 hours before surgery, of course, to maintain empty stomach. And for patient with fluid overload, we can give some diuretics to decrease volume status. Moderate administration of crystalloids or colloids to maintain euvolemia and avoid congestive heart failure, exacerbation, pulmonary edema, and dilutional coagulopathies is considered appropriate. And of course, postoperative delirium and cognitive dysfunction are the most common complications in elderly patients, but are often neglected and in preoperative discussion and planning. Risk factors include underlying cognitive dysfunction, history of cerebrovascular event or accident, depression, age more than 70 years old, alcohol use or abuse, poor functional status at baseline, abnormal electrolyte levels, including low or high sodium, potassium, and glucose, of course, high. And the ASA, or American Society of Anesthesiology, developed the Brain Health Initiative to help improve postoperative cognition dysfunction, health literacy amongst practitioners. Let's talk a little bit about mortality. Most have discovered age to be an independent risk factor along with the invasiveness of the surgery and baseline comorbidities. A Medicare database review, a mortality rate of 0.23% on the day of surgery, 0.66%, 30 days mortality rate with higher risk associated with age over 85%. And additional mortality risk factors include diagnosis of ischemic or non-ischemic heart failure, emergency surgery, invasive surgeries like abdominal, aortic aneurysm repair and thoracic surgery, or big surgeries, and delay in emergent surgical interventions that should be done immediately. Thank you very much for attention. Hope this video is useful for you and can help in your practice. This video is made only for educational purpose, and I have nothing to declare, and thank you very much.